Good evening, friends. I am Dr. Nigam Prakash Narayan, retired professor and head of pediatrics of Patna Medical College and senior vice president of my organization, Indian Academy of Pediatrics of 2020. I'm really quite privileged to address you on this platform of Dr. K.K. Agrawal's foundation. Over to the topic, please. Yes, let us share the slides now. Yes, I think we have to address something which is little known to the general practitioners. And I think it's very, very important for all the general practitioners, whoever are practicing medicine, even a young child or even a young adult can have this rickettsial disease. Next, please. Next, please. Yeah, next slide, please. Yeah. So if you go to the historical aspects, if you see this disease actually was rampant during the actually war of, Lenin. And that time also, it was dreaded disease from that angle because it led to a lot of fatalities. In fact, for Indian perspective, it is reported from many states, and that's why I think it's a very good platform to address you all. It is reported from Jammu and Kashmir, Himachal Pradesh, Uttaranchal, Rajasthan, Assam, West Bengal, Maharashtra, Kerala, and Tamil Nadu. And in fact, in last few years, even in Bihar and UP, we are getting lot many cases of acute encephalitis syndrome on account of these scrub typhus. So it is getting a lot of, magnanimity in the different states also. There is a high magnitude of scrub typhus, spotted fever, and Indian tick typhus caused by R. conori. Next, please. Next slide, please. Yeah. Yes. So there is one called tick-borne rickettsial disease. This is little less known, so we'll go to family Rickettsia. This is actually this holds a position between bacteria and viruses. They are non-flagellate, gram-negative, pleomorphic coccobacilli, and they are adapted to obligate intracellular parasitism and transmitted by arthropod vectors like lice, fleas, ticks, and mites, in which they are found in the alimentary canal. And in vertebrates, including humans, they infect the vascular endothelium and the reticuloendothelial cells in particular. And that's why there's a lot of vasculitis. Next, please. Sorry for a little delay because the slides are coming little late. Yes. Rickettsia, the genera Ricketsia, Orientia, and Erlicia. These are the different families. Next, please. Yes, if you go to the biogroups of the Rickettsiae family, there are 4 biogroups which have been located. The spotted fever group has Rocky Mountain spotted fever, which is the vector for which is lick dogs and the rodents. The host organism is Ricketsiae, whereas rickettsial pox is by mite mice. Indian tick typhus is by tick dogs and rodents, whereas typhus provazeki is by louse human, and most importantly is the scrub typhus, which is the most common actually type of typhus which is found in India. This is scrub typhus, which is due to Orientia musi, and this is spread by chigger rodents. That is the larval stage of the rodents. And there are miscellaneous like tibola, that is tick-borne lymphadenopathy, or debonel, that is derma center-borne necrosis eschar lymphadenopathy. These are rare ones. We are mainly concerned with scrub typhus in our country. Next, please. Next slide. Yeah. Next slide, please. Yes. Vasculitis, vascular leakage, edema, tissue vasculitis itself. And if you go to the next important or contact with the dogs. Nowadays, I think dog quite pet in most of the families, and that's why I think this is important that the dog approximation to the humans. I think this can be a factor in the that kind of ticks which are there in the dogs. They can spread the disease. So scrub typhus forms the largest group in this group, that is say up to 62.8%, which is followed by spotted fever 32.6% and typhus, endemic typhus as 4.7%. Next, please. The headache and myalgia is also very important symptom which must be actually taken notice of. There is severe frontal headache and generalized myalgia, as simple as in dengue. More than dengue and chikungunya, there is a lot of headache, and there is most of the myalgia is in the lumbar region, thigh, and calf. The headache is also noted even in, you see, young children. They may be quite intractable to therapy. Next, please. Next, please. Right. So, importantly, there is a rash, and the spotted fevers could be even a spotless too, mind you. This is the opening remark which I am actually forwarding. So, it is not that all the spotted fevers have the rash also, but still rash becomes very apparent in most of the cases after 3 to 5 days. Initially it is pink, blanching, discrete macules, which subsequently become maculopapular, petechial, or hemorrhagic, and occasionally petechiae enlarge to form ecchymosis, and even gangrenous patches may develop. This is the typical finding of this disease, that the gangrenous patches can be there in the earlobes, scrotum, digits, nose or limbs, and this is a sign of vasculitis and thrombosis. And the distribution of rash is initially near ankles, lower legs, palms, and soles. Next, please. The hallmark of this disease is eschar. This is a necrotic eschar, which is resembles a skin burn of cigarette butt, as if somebody has burnt the child with you see, cigarette which is already on, which is smoked, and that is actually touched on a skin and forms a necrotic area. This kind of feeling this scar gives. So a scar is a black necrotic area, and this necrotic scar usually has an erythematous rim and is also associated with regional lymphadenopathy. For eschar, you have to undress the child and look at the hidden areas, and sometimes you can find them. The systemic feature wise, the gastrointestinal symptoms, they are like nausea, vomiting, abdominal pain, and diarrhea. Constipation is rarely seen, of course. But respiratory symptoms, they include cough and dyspnea. Next, please. Yeah, if you see this child, in fact, he has got the rashes. The eschar is not prominent at that stage, but you can see the rashes which are actually maculopapular here. But if you go to the next, yeah, next slide, please. Next. Yeah, now you can see little, you see in from a closer angle, the rashes now here are, even you see chymotic. Here you are seeing there are purpuric and there few of them have qualis to form the chymosis. Next, please. Yeah, here you see the gangrene. This is a hallmark, you see. Eschar and gangrene. These are the two things which always should be actually hinting you towards this disease of vasculitis, which is the rickettsial disease. That's why you are seeing here the gangrenous patch in the ear lobule of the child. Next, please. And here also you are seeing lot many, you see, chymotic patches and the purpuric rather patches which are there in the palm of this child, and sometimes the soles are also studded with these kind of you see rashes. Next, please. Next slide, please. Yeah. So the actually this disease got its name from typhus, which is means which in German means that cloud or smoke. So there is a cloudy state of consciousness which was actually seen in this disease earlier on, but not all the cases get it. But definitely this is one feature which may be a prominent one in the latter stages of the disease. There may be dizziness, there may be drowsiness, there may be disorientation, tinnitus, photophobia, delirium, meningismus, and visual disturbances also. So these are the features which are neurological, and they take their, you see, credential for the name of this disease. This is typhus. Yes. Next, please. Next. Yeah. You see these are the life threatening manifestations. If you see the respiratory manifestations like interstitial pneumonitis and non cardiogenic pulmonary edema, which is secondary to pulmonary microvascular leakage, they are occasionally, of course, they are occasionally observed. Neurologically, we have told you about this meningoencephalitic syndrome and AES, that is acute encephalitic syndrome, which is known to occur with rickettsial infections, and the differential diagnosis of which will be aseptic meningitis and encephalitis in patients exposed in the endemic areas. The renal manifestations like acute renal failure is also associated with a very bad prognosis, as is the disseminated intravascular coagulation, which can lead to, you see, hepatic failure, gangrene, and myocarditis, which is, of course, rare, but then you should not wait till that long. Next, next, please. Yeah. Yeah, now you see, this is you should have a high index of suspicion. This slide is a little crowded, but I will tell you that fever with rash or fever without any symptom, fever with edema, dengue-like illness, or meningoencephalitis should always arouse the suspicion of this disease. Suspicion is very, very important, and many times even without investigation you can treat these children. I'll tell you which drugs are very, very important, but if you treat them early, I think they will be just okay. Elicit history of tick bite, the ticks on clothes if they are found, if they are playing in areas like in uncut grass or weeds or low bushes, Animal sheds in proximity of the homes, like dogs, contact with the pets which are infested with ticks, and travel to forest areas, or there is occurrence of similar illness in the family. The fever, rash, edema, scar. These are the four very, very important features which I think must be combined and seen together. Not, and if you go to investigations, you may in the initial stages get a leukopenia, but leukocytosis may be in later stages. Thrombocytopenia is also there, as is the raised ESR and CRP. The hyponatremia and hypoalbuminemia is a very common finding in this disease. And of course, mildly elevated hepatic enzymes may be there. You have to exclude other viral like dengue, infectious mononucleosis, measles, or enteroviral infections, even bacterial infections because of the gangrene which are happening here and there. You have to go for diagnosis of meningococcemia must be excluded. And the typhoid, leptospirosis, or scarlet fever, and protozoal like measles, and rarely Kawasaki disease also should be excluded. Next, please. Laboratory findings wise, no single laboratory finding is specific for early diagnosis, and that's why high index of suspicion, and even you see early treatment, even without getting a laboratory confirmation, is a very, very crucial part of this treatment of this disease. Next, please. In hematology, we have already told you that total leukocyte count may be normal to low normal with marked shift to left. Later in the course of disease, it may show you leukocytosis. The low platelet counts are present in about 60% of the cases, thrombocytopenia. And ESR is usually high, as is CRP. Next, please. In biochemistry, hyponatremia and hypoalbuminemia, they reflect increased vascular permeability, and they are present. Thrombocytopenia, hyponatremia, and a normal to low leukocyte count are certain clues to early diagnosis. Hepatic transaminases are frequently elevated, and blood urea may be elevated due to pre-renal mechanisms. Next, please. In serology, I think this is the main confirmation of the diagnosis, and no other than ELISA is important. ELISA IgM for this disease, scrub typhus, should be ordered. The research oriented investigations are microimmunofluorescence, very costly, not practicable in the community diagnosis, and immunoperoxidase assay and latex agglutination, as is the indirect hemagglutination. I tell you, ELISA is the best one, which must be done. And the Weil-Felix test was available nowadays, very rarely available, but I think that is not confirmatory. So, ELISA is the one confirmatory test which must be performed. Next, please. Yeah, well, Felix test, I think the sharing of antigens between Rickettsia and Proteus is the basis of this heterophile antibody test, which is a very old test, but I think not practiced nowadays. And it has got a very poor sensitivity of the well Felix test, and that's why it is not practiced nowadays. Next, please. Yeah, this immunofluorescence assay is a very good sensitive test, and is thought to be gold standard But of course, as I told you, it's a very costly test and it's not available in India right now. It usually provides even retrospective diagnosis and sensitivity also. It's a very good test for research purpose, I must tell you. Next, next please. The other rarer tests are PCR, which can be done to detect rickettsial DNA in whole blood, Buffy coat fraction or tissue specimen, and it is the most rapid assay for the diagnosis, but varying level of sensitivity, high cost, and non-availability makes it unpractical for our country. Immunohistochemistry and isolation of the organism is extremely unpracticable, but of course it can be done as a research tool. Next, please. Yes, so diagnosis is mainly by compatible clinical presentation and high index of suspicion. Tick bite or tick exposure history should be taken. Epidemiological data should be confirmed because there are states where it is prevalent and there should be high index of suspicion there. Suggestive laboratory features, which can be, of course, not that significant and specific. Rapid effervescence with the appropriate. This is, I think, the most important tool in diagnosis in clinical practice, I tell you. Rapid effervescence with appropriate antibiotics. Which antibiotics we are just going to unfold right now. Next, please. Yes, next. Yeah, definite treatment as early as possible to avoid severe disease and fatal outcome is the goal primarily of the physician. And various antibiotics useful for treating rickettsial diseases are tetracyclines and preferably doxycycline. In the tetracycline also, it is doxycycline which can be used at any age because there is no question of risk of a side effect like teeth staining due to tetracycline group of drug because it is to be used only for 5 to 7 days. That's it. So there is no harm in using doxycycline even in younger children, as young as 2 years, 3 years. There is no problem in using doxycycline, and that's why this is the first choice of treatment which must be used, and followed by chloramphenicol and macrolides like clarithromycin, especially clarithromycin. Out of all, not azithro or roxythro, but clarithromycin has been advocated in this disease if others fail. But still, I tell you, there is no better choice than doxycycline. Very rarely you can use even fluoroquinolones like ciprofloxacin or ofloxacin, pefloxacin or levofloxacin. But mind you, the best treatment so far, and it is a confirmatory and diagnostic tool also, to use doxycycline and find the relief immediately within 24 hours. So doxycycline is the wonder drug in this disease. Next, please. The drug of choice is doxycycline, as I told you, and it should be used in a dose of 5 milligram per kg per day in two divided doses for children below 45 kg, and 200 milligram per day in two divided doses for children above 45 kg. So below 45 kg, it is very simple, 5 milligram per kg in two divided doses. And the duration of therapy should be at least 3 days after defervescence or minimum 5 to 7 days. So I think you can take it as 7 days uh, at large. So 7 days therapy with doxycycline is a wonderful way of treating this disease, and it is even a confirmatory test that this disease was there without even we see going to in other investigations, you can be confirmed that this is only rickettsial disease. So there is next, please. I think the slide is not moving. Yes, clarithromycin, I have already told you, it's a valid alternative to tetracycline and chloramphenicol. You don't have to go to up to this level. You should start off with doxycycline and you will be happy. Next, next, please. Yes, supportive therapy is important, as you know that it's needed in such critically ill patients as iatrogenic cerebral and pulmonary edema is easily precipitated due to pre-existing microvascular leakage. So the supportive therapy is extremely important, and judicious use of corticosteroids is advocated by some in meningoencephalitis. Supportive care is also needed for hypovolemia, coagulopathy, seizures, and intercurrent infections. So they have to be treated symptom wise. If they have hypovolemia, you have to treat. If there is coagulopathy, you have to treat. You have to treat with anti-epileptic drugs, or intercurrent infections. If they are, you have to use antibiotics. But other than that, of course, you don't need antibiotics. Seven except doxycycline. Next, please. Yeah, I think I'll end up my talk with a saying of George Santayana: "Those who cannot remember the past are condemned to repeat it." And that's why I think we have to know the past of this disease, and we have to treat it very competently with simple doxycycline. Thank you very much for patient visualizing. Thank you. Over. Thank you very much for giving me the opportunity. Heart Care Foundation of India by Dr. Legend Dr. K. K. Agrawal.